Hello, I'm Dr. Mary McCarthy, Interim Medical Director of the Oregon Wellness Program. We have asked all our clinicians who are providing services through the Oregon Wellness Program to watch this orientation webinar. You will hear from other experienced clinicians who have been active in both medical societies and healthcare wellness programs, as well as from a practicing attorney who will discuss the relevant legal statutes. After watching the video, the Oregon Wellness Program will provide each clinician with a $100 stipend, and you will also receive continuing medical education credits through the Oregon Medical Association. Please note the deadline for viewing the video is the end of February 2019. I hope you will find the information that you are about to view helpful, and feel free to reach out to me if you have any questions. Thank you. I'll now give a little history about the Oregon Wellness Program. The Oregon Medical Board maintained its own successful health professionals program called the HPP for 20 years, approximately from 1990 to 2010. In 2010, the HPP was replaced by the Health Professionals Service Program, also called HPSP, per a legislative mandate, as a statewide confidential referral source for rehabilitation and monitoring. But the HPSP was not a treatment program. In Oregon, there are approximately 18,343 MDs, DOs, and PAs, with an annual growth rate of about 4%. As many of you know, physicians are reluctant to seek treatment for mental health issues. Out of this concern developed several wellness programs around the state. The first was Oregon Health and Sciences University, who developed a residency wellness program, and Mary Moffitt will speak about that program later. The second program to develop was through Lane County Medical Society, and Tom Faria will speak on that program also. Then came Medical Society of Metropolitan Portland, and after that, 2 other medical societies that we'll talk about in a few minutes. It's been a long-time vision of many Oregon healthcare leaders to have a program that would allow physicians to get treatment in a confidential setting. Around 2014 to 2015, these healthcare leaders began to meet to develop such a program. Out of this arose the Oregon Wellness Program to serve MDs, DOs, and PAs. There's been talk of possible expansion in the future to other practitioners also. So the OWP wanted to secure funding for this free counseling and treatment service. They also wanted to do outreach to educate physicians about the Oregon Wellness Program services. The OWP wanted to be a catalyst for coordination of regional programs and to support the infrastructure to serve Oregon physicians. The OWP has also developed a goal of telemedicine service that would be statewide, and we're working on this currently. Another goal for the OWP was to establish research that would share evidence-based outcomes. Dr. Gerard will talk about this also in today's program. Currently, we have 4 active medical society programs within the Oregon Wellness Program. Central Oregon Medical Society joined in April of this year. Lane County Medical Society joined in November of this year. Marion Polk Medical Society joined in August, and Medical Society of Metropolitan Portland joined in September of 2018. The Oregon Wellness Program prides itself on confidentiality. The clinicians who treat the patients generally have no diagnoses, and symptoms and treatment plan are documented in the chart by the clinician. Clinician chart notes are not sent to third parties without the consent of the physician client. There's no insurance billing and no requirement to send clinical information to a third party. So, what do we cover in the Oregon Wellness Program? We cover up to 8 sessions in a 12-month period. There's no cost to individual participants, and it's not designed for couples treatment. This slide outlines where you can get further information. The first is the website for the Oregon Wellness Program. The second item is the 541 number that physician clients or PAs, or when it's expanded to other practitioners, they can call this number and find out information on how to make an appointment. Or the person can contact their medical society to get further information on making appointments. The last item on this slide is the contact information for the Foundation for Medical Excellence, which is the organization that the Oregon Wellness Program operates under. The foundation is a 501c3. And if you have any further questions, you can call the foundation phone number and they will help you out. We also have available informed consent and intake forms for any clinicians who participate in the OWP. And those will be sent out to the clinicians on a flash drive, which we'll provide later to anyone who becomes a clinician for the program. If you have questions about those consent forms, you can also call the Foundation for Medical Excellence and they'll connect you with one of the clinicians in our program who has lots of experience with those forms. How does one bill for the Oregon Wellness Program services? Bills will be sent to the Foundation for Medical Excellence. Again, they are our 501c3 organization. The OWP, as I said before, is a program of the Foundation for Medical Excellence. The Executive Committee for the OWP has established guidelines for the development of this program. And then there's a larger group of healthcare professionals who have band together as the Oregon Wellness Coalition, and this group includes representatives from multiple medical organizations around the state. And they act as advisors, advocates, and supportive clinicians and other practitioners to give the Executive Council, or excuse me, the Executive Committee recommendations. I've listed here several references that I thought would be of help. The first one is a book written by Michael Myers and Glenn Gabbard, both of whom are psychiatrists. And this book is titled The Physician as Patient, a Clinical Handbook for Mental Health Professionals. It was published in 2008, and we have some copies of this book for those who need it. Many of you may already have this book in your library, but if you would like a copy, please get a hold of us and we'll provide you with one. The second book was recently published in 2017, and this book is Why Physicians Die by Suicide by Michael Myers, psychiatrist. And this book is really worth reading because he gives a lot of vignettes of different situations where physicians have gone on to commit suicide and some of the reasons that have led to this. I think it would be very informative for all clinicians to have read this book. The Oregon Wellness Program is hoping that we can intervene with physicians who need help before they get to the point where they might be suicidal. But we know that we may receive phone calls or concerns about those kind of issues, and that's why I include a discussion of the Why Physicians Die book. And then on the next slide, I included some information from the National Suicide Prevention Lifeline, which reviews some of the signs of suicide, possible suicide in the future. And this is also an 800 number that you can give to patients that they can call if they get into trouble. And if you go to the Oregon Wellness website, you'll also notice that we have listed some of these resources there in case a physician gets on the website and is in a crisis. There will be some resources for them to call. And here is a list of the warning signs of suicide. I'm sure all of the clinicians in our program know these signs, but I thought it was helpful to just kind of go over these again to remind people to ask about these symptoms when you see a new client. So the first one is talking about wanting to die or to kill oneself. The second is looking for a way to kill oneself, such as searching online or buying a gun. The third is talking about feeling hopeless or having no reason to live. The next is talking about feeling trapped or in unbearable pain. Also, talking about being a burden to others. Increasing the use of alcohol or drugs is another sign. Acting anxious or agitated or behaving recklessly. Sleeping too little or too much. Withdrawing or feeling isolated. Showing rage or talking about seeking revenge. And the last one, displaying extreme mood swings. I hope that this presentation has been helpful to give you an introduction to our program, and now we will have other speakers coming up. Thank you.
Of OHSU's resident and faculty wellness program, which has now been in place for 15 years. And I'm here to discuss what we've learned over these years when we've listened to the physicians that meet with us. And as Dr. McCarthy mentioned, I do not have any financial interests or commercial interests to report. So, what do we know? In the beginning, when we began this program, and also when we have been in discussions about building the Oregon Wellness Program statewide, we recognized there was a great deal of unmet need that is given, that our physicians and of course other clinicians are at high risk, but physicians particularly at a higher risk of depression, certainly of burnout, as well as suicide. There was an excellent film that was made about 10 years ago, Struggling in Silence, that was produced by the American Foundation for Suicide Prevention, specifically looking at the silence surrounding physician distress and the limited capacity that they've had to access personal health care, whether that be medical health care or psychological or psychiatric health care. So we know there is an unmet need. Numbers, there have been a range of numbers in terms of the number that has been cited over the years of physicians who die by suicide. You will hear the 300 to 400 number, although currently AFSP, the American Foundation for Suicide Prevention, Christine Moutier has indicated that we really don't have a definitive way to track that. There is no national study that people are actually reporting into a database. So we can't be 100% confident that the number is not higher or lower, but that's an estimate. Clearly, the estimate of physicians who are experiencing depression being approximately 40% in one report, and burnout levels 50 to 75% depending on the study. These are clearly very high numbers. And so we asked the question, what can we do to protect the health care of physicians and other clinicians who are working to protect us? We look at our goals. Ideally, we're looking for resilience. We would like all of us to find a balanced place where we are emotionally steady and grounded and not detached or disconnected and not over-involved. That's where all of us would value and appreciate being able to practice in that place. In reality, what we are aware of, what we have seen, is the trauma, the traumatic exposure that these young residents and fellows, as well as clinical faculty, experience as they go through their practice years. And that trauma can range from difficult negative outcomes or adverse events. It could be a medical error, a near miss, or the tragic, unexpected death of a patient, particularly a patient that clinician was connected to or knew well. In addition, over the recent years, there has been more and more awareness that physicians are at times targeted with verbal and even physical threats. And this can be very distressing, whether it's coming from the actual patient the physician is working with or a family member. Physicians are very, very upset and come and speak with us when they are threatened or have been threatened by a patient or a family member. Other experiences include interpersonal conflict. Every workplace, of course, comes with some degree of conflict, but the level of conflict that physicians can experience in the workplace can be quite high. It's important also to mention the fear of and the reality of litigation, patient filing legal claims, the reality of patients filing complaints with the medical board, or the board opening even an investigation. All of these are professional concerns that can have a tremendously negative impact on a clinician, on a physician practicing. And I'm sure many of you are aware of the prevalent use of a Press Ganey survey where patients are asked to rate, just like they would rate a restaurant or a movie. They're asked to rate their physicians, and at times these negative reviews, they can be quite positive 99% of the time, but even the 1 or 2% negative reviews then being published nationally, not nationally, but locally, can be very upsetting to a clinician. So these cumulatively represent a threat to professional identity. So what can be some of the negative outcomes when one has experienced that level of distress within a practice? We're all familiar with the self-doubt that can come with the physician population. We recognize the imposter feelings. I'm sure many of you are aware of that. The fear, the secret belief even that I don't belong here. I somehow got through medical school, somehow they didn't find me in residency yet, but someday someone is going to figure out that I don't have what it takes, I'm an imposter. And this is prevalent, it is secret, and it can be tremendously negative impact on the individual doctor, who will not share it unless they feel safe that they can talk about this. How they respond to this is often with compulsive overworking. Substance abuse can come up, and withdrawal or isolation from the important supports in their life, from their peers, their family, and their friends. Downstream, this anxiety can actually result in PTSD-like symptoms. Of course, increasing burnout, increasing the risk for depression. In addition, anger is not unexpected. You'll hear people talk about someone acting out. We used to talk about disruptive physicians. Now we recognize it's not really the person who's disruptive. The behavior might be in a certain context, and it certainly expresses frustration and sometimes despair that they're not able to practice the way that they long to practice and the way they've been trained to practice within the current systemic issues. Many physicians in these situations do leave medicine. Almost every physician who has been surveyed, if they are asked, can you name a colleague, can you think of a colleague who has left medicine due to the recent stressors, they will be able to tell you stories of friends or colleagues who have left the practice of medicine. And also the high risk of suicidal ideation as well as death. So given all of this background, where do our physicians find help at work? This was a study that was done looking at residents and faculty across 3 specialties: surgery, emergency medicine, and anesthesia. And as you can see, the light-colored boxes are where they feel very likely they would reach out, they would feel comfortable reaching out to. And as you'll notice, it's often a peer, a resident colleague, a faculty colleague, a chief resident. Not necessarily their leadership, not necessarily an EAP or a clergy member, and not necessarily a physician health program, which is what PHS is. And not necessarily a clinician in mental health. So given that, we began to ask, what are the barriers? What's preventing physicians from accessing healthcare? And we recognize stigma, we recognize cost, access, how am I ever going to get there? I have to drive downtown Portland in between clinic. And also valid, real concerns about privacy and confidentiality. And as I mentioned, the fear of reporting to medical boards or disclosing on credentialing applications or life insurance applications or other types of institutional questionnaires, that often there was this misbelief, an incorrect belief, that the Oregon Medical Board, for example, was going to ask them, have you ever seen a psychologist? Have you ever been treated for depression? That they would actually be screened this question. They believe this. Still today, on the ground in Oregon, physicians believe that there is the likelihood that they would have to disclose this. And this is completely incorrect. And there's a great deal of work that was done nationally by the Federation of State Medical Boards to address this and to strongly recommend the changes that the OMB has made. The only questions on the OMB license applications now address impairment. So I'll talk more about that in a moment. They also asked, who are these providers? Do they know about working with physicians? And what benefit would there actually be if we met with anyone? How is that going to help? That I'm sleep deprived, that I'm feeling burned out, that I'm being yelled at by my attending or by my chair. How is this actually going to help? So again, we in the beginning addressed these barriers and specifically went out into the community of physicians at OHSU and named each of these barriers and gave correct information, including information from Kathleen Haley, who is now the Executive Director Emeritus of the Oregon Medical Board. And she provided a statement that we have now shared with all of our doctors, that the board encourages physicians to receive treatment upstream and is only screening for impairment, not illness or treatment. So our model was a model that looked at prevention via education, a great deal of outreach, consultation, meaning that we may or may not meet with someone, they may just want to consult with us, as well as treatment. Our model is free coaching, counseling, and medication management. And our role is to advocate. We have spent many years in this program advocating with hospital leadership, program directors, etc., advocating for the resident or the faculty physician. We do not get into the role of doing fitness for duty evaluations. That's what has sometimes been called becoming the company doctor. We are not in that role. We are separate. We refer out for those. But in our consent, whenever anyone comes in to meet with us, we explain both confidentiality as well as the limits. And we explain that if there's imminent risk of danger to self or others, or imminent risk to patient safety, that may be a situation where we may need to share confidential information to keep them safe or to prevent imminent harm to a patient. Very importantly, from the very beginning, we were asked, please not chart in the hospital record. We no longer have, we never have had any documentation within the hospital record. No one can look these visits up in Epic. Instead, they can either have a paper chart or they can agree, most of them do, to be in our separate access database that's completely separate from OHSU. Another important part of our model is our team approach. These are not individual clinicians who practice without consulting with each other. We have a weekly team meeting where we discuss challenging, difficult clinical decisions, and we consult with each other, and every person who comes in to meet with us gives us that consent to consult. We also, as I mentioned, refer out. We refer out for specialized treatment, perhaps for DBT program, or for example, for an eating disorders program or a substance abuse program. And we coordinate care with all of these clinicians across the community. Our services at the moment have now expanded to all OHSU, Legacy, and Providence trainees. So every resident and fellow training anywhere in the Portland metropolitan area who is in any of those three hospital systems, OHSU, Providence, or Legacy, is now eligible for free services in our program, as well as all School of Medicine OHSU faculty. So warning signs, Dr. McCarthy spoke very importantly about the warning signs that we also have noticed over the years. There are cognitive warning signs, social warning signs, emotional warning signs, and these you can read, including changes in behavior, changes in work approach to work, how conscientious, and importantly, you'll hear people talk about someone has become more withdrawn or more isolated. Also, a warning sign can be somebody becoming more activated, even more high energy than usual, even more fastidious than usual. And of course, there can be physical changes as well if there's substance abuse involved or other medical or metabolic issues that may impact cognitive function. So how we respond to these, and I've spoken about that, we meet weekly. We have a very low bar for medical leave recommendations, and we also refer for fitness for duties if we're very concerned. And I want to emphasize that never in 15 years has any physician ever refused to take a medical leave when we have recommended that that would be in their best interest when they are ill or at imminent risk of impairment. They have never said, nope, sorry, I'm going into the OR tomorrow, despite your recommendation. Everyone has said, oh, that makes sense. I don't want to. I really would want to go back into work, but I hear what you're saying. I'm not as safe as I want to be right now, and they've agreed to take a medical leave. So as a result of the model that we have built, we believe that we are reaching people upstream. You can see with our utilization that we went from 5% of the resident and fellow cohort in 2004 to 34% in the last academic year. 34% of the eligible residents and fellows at OHSU participated in our program. Our faculty visits have also significantly increased from an initial six faculty members meeting with us our first year of eligibility for them, and recently, last year, 130 faculty members met with us. So our utilization is over 100 visits a month at the moment, and we believe that we are reaching people and we are seeing people and helping them move through the trauma of practicing in medicine. We are seeing every day post-traumatic growth. And as all of us know, in monitoring and substance abuse programs, the data is clear. 70 to 90% remain abstinent or sober after 5 years. And we think we're seeing very similar outcomes in our clinical population, although it is not a substance abuse treatment program. Here are some quotes. These are some of the quotes that we've heard over the years from residents and faculty. I think everyone should receive these services, and of course we've had people tell us that they think that we should mandate it, that everyone should have to come and meet with us, but we have a voluntary program and not a mandated program. In summary, we believe that physicians will reach out to us. They will if we remove the barriers and offer safe professional services, which is what the Oregon Wellness Program is now offering statewide. Here are our two websites for our wellness program and our peer support program. You're welcome to reach us and ask any questions that way as well. Thank you, and thank you for inviting me to join you today to tell you about our program.
Good afternoon. I'm Tom Farri. I'm a psychologist in Eugene, Oregon with Cascade Health. And since 2012, I've been working with the Physician Wellness Program through Lane County Medical Society. And what I'd like to do is to give you an overview of my clinical perspective in that work over the last several years. Dr. McCarthy gave you an excellent overview of the OWP program. Dr. Moffitt gave you an excellent overview of the OHSU program. And what I'd like to do is talk about my experience as a psychologist working in Lane County. Okay. So I'd like to start off with, and these will seem familiar to what you've seen before, some of the characteristics I've noticed in physicians are obviously very bright, they're quick learners, mastery-based, goes without saying, self-confident, driven, and I see an interesting blend of assertiveness. At times being assertive to the point of being arrogant, at times being quite humble, and sometimes that fluctuates between arrogance and almost a naive fragility when experiencing personal or professional challenges and difficulties. They clearly value excellence, altruism, like to be in control, and in that sense don't like conflict. Dr. McCarthy mentioned the book, Why Physicians Die by Suicide. These are some of the key characteristics that Michael Myers mentions contributing to suicide. And you can see the drive, the excellence, the demand to do more, to serve the community, to serve patients and their families. Nowhere in that is any implication towards self-care. So some of the contemporary challenges, certainly the delivery system itself with the volume, the challenges of checking boxes in the EMR, the overall workload, physicians having, one physician recently had 800 patients added to her caseload. And then the acuity and the complexity of difficult cases, seeing them for the first time with chart notes perhaps being incomplete, then their personal relationship, family, personal health issues, wrapped around the values that physicians have toward altruism, placing the patient first, being thorough, being accountable. Those factors all contribute at times to a perfect storm. So the process that I've used, not that you would use this, but one that I found helpful, is when I first meet with a physician, I address confidentiality and privacy. They filled out the informed consent forms. They're very familiar with HIPAA, but I just stop and ask, do they have any questions? Interestingly, most don't have any questions. They're very comfortable with the informed consent material that you will be receiving as a OWP clinician. If there is a question, it's as Dr. Moffitt referred to, it's, are your notes shared? Do other providers have access? And the answer clearly is no, that our notes are sequestered and carefully siloed so that there is no access. And with that, confidentiality tends to melt away. I then want to hear and clarify the presenting concern, what brought them in, what's on their mind, and we spend some time going over that. And one of the things that I found helpful, which I'll explain momentarily, is I'm listening to understand what's important to each individual. In most cases, mastery, competence is important, but it could be family, it could be status, but I want to listen to hear their underlying values and then clarify, based on their values and the situation, what the individual hopes to accomplish, what brings them into the physician wellness program. And so that's how I start off, and then we proceed from there in what's clinically relevant. But I would like to pause for a moment to show you the utilization patterns over the past 3 years. This is utilization through Lane County Medical Society from January through December 2016. You can see on the pie chart that the bulk of the concern that year was dealing with couple issues, often marital issues. Now, as Dr. McCarthy mentioned, we don't see couples in the physician wellness program, but these are physicians coming in to talk about their intimate relationships, their primary relationships. So that was a dominant issue that year, along with burnout, and you can see, anger, anxiety, depression. That year, if I remember correctly, several physicians retired, and career transition was an important issue to talk about how they plan to adjust in the next chapter. Now we had a different tracking system, so you see the chart looks a little bit different from January through December 2017. But in that year, there were quite a number of concerns regarding burnout, exhaustion, practice management, along with the continued concern regarding primary intimate relationship issues. Work-life balance is often mixed in with burnout, and one of the themes there I see presenting is physicians trying to manage the workload, resulting in conflicts with the MOA, with coworkers, with colleagues, and trying to sort through how they can proceed and manage conflict there, sustain relationships, and reduce attrition on the part of their team members. So that in 2017, we saw a total of 61 cases in Lane County. And then in 2018, to date, January through September, you can see the primary concern again is couple relationship issues, along with burnout, anger management. So there's practical issues. Coworker conflict is in there. So physicians are presenting with a variety of different concerns in our practice in Lane County. On the right, I added, so you can see since Central Oregon Medical Society has come on board, beginning in April 2018 through December 6th, there were 13 cases from Central Oregon, and Marion and Polk County came on board August 9th, 2018, and 2 cases have presented from Polk and Marion County. So the program is being used. So for all those different reasons, one of the things that I observed is when physicians are challenged for whatever the reason, it triggers a sense of vulnerability. It triggers a feeling of weakness. Think of mastery being the dominant value. So if I don't feel competent, if I don't feel capable, it triggers a sense of weakness, leading to a sense of stigma, and certainly not being okay. Often implicit memory that's unconscious is the patient comes first. I want to mask emotional pain. I want to avoid vulnerability. That's where, as Dr. Moffitt mentioned, people often try to work harder to seal away and isolate themselves from vulnerability. And that can certainly lead to isolation, and that's a passport to secrecy and in turn shame. So often that's the kind of the lay of the land in the background that's operating in a physician's mind in the clinical office, or at least in my clinical office. So one of the things that I would like to do is when there's work stress, when there's workload, when people can't keep up, or where there's difficult cases, or there's coworker conflict, or there's marital or relationship problems, often the reaction is absolutely appropriate to the situation. That the individual feels frustrated, feels angry, feels lost, feels fallible, feels incompetent, feels that they're sloppy. And often that reaction in the situation, in my perspective, is situationally very appropriate, that they would feel in that manner. It's very human. However, the key thing that I'd like to share with you today is my concern about the physician's reaction to the reaction. Their reaction often triggers the inner critic. Think of the physician being valued, the values being mastery, competence, being thorough, duty, the patient comes first. When those values are challenged, what I often hear is people becoming self-critical. I'm not adequate. I'm not enough. And it leads to cognitive distortions out of a standard CBT model of overgeneralization, all or nothing thinking. I'm not competent. I am competent. I disqualify the positive, focus on the negative, the thing that didn't get done. Labeling, I'm not capable, I'm a jerk, some type of negative label can be assigned, sometimes verbally or sometimes silently in an individual's mind. So what I'd like to do is I just made a couple of notes. Let's take a particular situation in which a physician receives a complaint. It could be patient complaints, a pattern of patient complaints. It could be a complaint or an investigation from the medical board. A natural reaction that's very human is anxiety, sense of danger or threat. The complaint triggers a procedural review. The review reveals some inconsistencies, perhaps some oversights on the part of the physician, on the part of the staff that they supervise, and that can trigger an overall practice management assessment, which sets the stage to find even greater vulnerability, which can lead to that inner critic of, what else am I missing? Why didn't I catch this earlier? Why I was too complacent. So I hear that inner critic surface across the variety of different problems that I outlined earlier. And often that inner critic really amps up the volume at night, laying in bed, thinking about what I need to do, which then compromises sleep, which then certainly compromises coping skills. So the model that I'd like to share with you, that at least I've found helpful, comes from acceptance and commitment therapy, where in this initial slide you have a model of what's called psychological flexibility, where the person lives in the present moment, views themselves as larger than what's occurring at the present time, driven by their values, what's important to them that provides purpose and meaning, leading to committed actions consistent with those values, and a willingness to accept distress, the negative feelings that come along with situational problems that emerge. So that's a model of what's called psychological flexibility. This model of psychological rigidity, people then, let's say that physician has the complaint from patients or from the medical board, it can create a fear of the future. What's going to happen? Will I lose my license? Will I lose my practice? Will I be able to support my family? Will I be able to support my lifestyle? And then there can be stories from the past. I remember what happened to this individual or that individual. Actions can become disorganized. It can lead to experiential avoidance, where the person does what they can to dismiss, disqualify, ignore, suppress unpleasant emotions, unpleasant reactions. And that's where physicians can get stuck. And this particular part is this kind of concept of fusion in this model. The reaction to the reaction is, I'm not okay, I'm not adequate, I'm not proficient, leading the person to then overgeneralize to their self-worth, to their competence. So one of the strategies that I found helpful is to try to help people move to psychological flexibility. So I mentioned earlier, when I first meet with people, I'm listening carefully to understand what provides purpose and meaning in their life, what gives value to their life. So I want to identify the main things that are important to them. So one of the definitions that I use is that the definition of emotional distress is the flip side of what a person values. So if a person's experiencing distress, that distress is often sensible, it makes sense, so we want to encourage that, sanction their values, and to realize that their distress really emanates from their values. Then we want to move to some mindfulness strategies, deep breathing, meditation, finding sources of gratitude, to help them get unstuck and live in the present moment versus living in the feared future. So to me, it's driven by a clear understanding of the physician's values, which is inherently validating, which challenges that inner critic at a very fundamental level. So diffusion uses many mindfulness strategies, and the goal is not to avoid distress, but to make it tolerable by diffusing that inner critic and helping people gain skills to manage that inner critic. And recognizing that, particularly laying in bed at night, those thoughts about what might happen, that feared future, are simply thoughts, nothing more. And that's a hard concept to convey, and it takes some work. But one of the benefits of working with physicians is they catch on quickly, and it can be very relieving when that occurs. So in working with a variety of different issues, the problems are solved based on what the situational variables are. We want to come up with solutions based on the situational variables that emanate from the person's values in an environment that's safe. The OWP was designed by physicians for physicians. We want to validate values, reduce avoidance and isolation, help them identify action steps that are in line with their core values, and it's all individually tailored, leading them to hopefully be more willing to buy in and accept and identify committed actions based on their values. So those are my perspectives on the clinical process that I've used, and hopefully they might be beneficial to you as well. So thank you very much for having me today, and I hope this is helpful.
Hi, my name is Beth Kaplan Westbrook, and thank you for the I've been involved with physician well-being and physician impairment since 1991, and grateful to many people who've been involved in physician well-being and unfortunately impairment over the years. And Paul Cooney, who you will hear later, has been an attorney who's well-versed in all this and has been very helpful to me with the sticking points that many of you who've already been trained or will be trained will come up with. In general, the Medical Society of Metropolitan Portland began its wellness program in January of 2015, and actually, our first case I agreed to take on before I even had a contract signed, but when there's need, you do what needs to be done, and that's what you'll all find throughout the state. The Medical Society made it a priority to protect the privacy, autonomy, and choice of every physician involved in the program. That was also my priority coming into any agreement. 8 sessions have been the limit to what we've been able to provide. We've looked at extending that. But the reality is that there is so much need, and though funding has been very generous through the foundation, the funding is not unlimited, so that's the reality. It requires that then session 1 you start thinking about what do you do at 8. And not everybody uses all 8, but some could use 300. So often I'm referring, if they prefer to stick with me, then I will take them into my private practice. Sometimes they have a need to go close to home or near where they're working or picking up their children, so the community is appropriate. They may need addiction medicine, they may need couples counseling, and whatever kind of triage role you take, you do. Sometimes it's multiple things. When a session is missed, we have found that it is important to give at least 48 hours notice, and often schedules do need to be changed because of work requirements. But we have often asked for a donation to the foundation. You can do that anonymously or with your name if you prefer, but that has been one way to kind of help take care of the potential losses of funding that happen when sessions are missed. And Janine at the Medical Society on the spot came up with a wonderful form for me. I often will, if there is a missed appointment, encourage them just to become a member somewhere, because if you're already investing in a donation, you might as well join and do it that way. It requires flexible scheduling, and I would say at least that initial appointment. I will take people early in the morning, I will take them late at night, I will take them on a Saturday afternoon if I have to get them in, if they're humming and hawing about how to get in and whether they can get in. So I often try to schedule the next one at a time that's a little more convenient for me, and that usually works once you have a relationship developing. Feedback has been very helpful, and we have done that in a routine way. One example is someone wanted specific information about burnout, and as many of you know, 2015 there were a lot of articles coming out of the Mayo Clinic, so I scurried and got a presentation together, did go ahead and forward that to this individual who wanted that information, and also just became a future talk. So you'll find you keep learning as you go, and that's the added benefit. In terms of the kinds of things that come into your practice, I've seen everything, as many of you have. Negative boss experiences, substances, grief, work stress, anxiety, lawsuits, the list goes on. Dealing with their children, all kinds of things. I believe a lot of the physician help is delayed. Often you'll get somebody who's had 1 or 2 sessions during their medical training or in a counseling clinic somewhere. But I think that the help is delayed due to the training, due to their hours, due to access. and changing schedules, especially those who work in hospitals. They can never predict a regular day off or things like that. In terms of suggestions that I have to anyone who is beginning to take on more of this kind of work, have knowledge of the other clinicians involved in the program, because we can help each other as we go through all this. There are questions, and I don't believe that any of us would mind being called just to have another voice or another opinion. And you can do that, and Paul will talk more about privacy around consulting. By no means report, and again, there are legal issues there, but if you are uncertain about whether you have to report or not, please consult. Know an addiction medicine specialist. This has become critical for me. I've had probably, not a lot of people, but a few, where it took, in this case, somebody who transitioned from the 8 sessions to my practice, and it probably took a year before he told me how much meth he was using. You know, it's not just alcohol and opioids, it's all kinds of things. So, and this was my early experience to physician treatment in 1991. It was all addictions then. And I would say take care of yourself. The initial sessions in this kind of work can be extremely difficult. People who've delayed getting help, and sometimes very, very extreme issues and a lot of emotion. Consultation is protected, and again, Paul Cooney will help us with that. And the privacy around records often comes up. So I do reassure people often that I keep paper, in my case I keep paper notes in my private practice, and that only if someone, I were court ordered to reveal those records, but that their notes are private, they would never go anywhere. And I will not do any fitness for duty evaluations in the context of these kinds of consultation. Again, I thank you all, and we are all, I think, very grateful to the foundation donors, because this program would not exist if it weren't for all the great help that people are giving their peers. So thank you very much.
Well, hello, my name is Paul Cooney, the aforementioned Paul Cooney, and I'm a healthcare attorney. I've been in practice 26 years. I represent Oregon Psychological Association, Oregon Counseling Association, and I specialize in mental health and how these things work. And I want to first thank you for being a participant in this program and receiving this training, because quite literally you may be saving lives, and we appreciate your efforts. I see the physicians and the physician assistants and others who go through litigation or board complaints, and I see the mental health issues that arise, and physicians seem to have an infinite ability to delay their own gratification, and it causes problems at some point. And so the nice thing about this program is it's designed by physicians for physicians, but it's designed to protect the confidentiality, and so things aren't all that different when you're setting up your file. The clients may have different issues than maybe you're used to, but for the most part, the confidentiality issues will all be the same as you normally have. In fact, it might be even a little bit greater, but there's confidentiality. You're not required to report somebody simply because they're seeking therapy. The medical board is quite clear on that. And the confidentiality that you're used to, HIPAA, Oregon privilege statutes, confidentiality all across the board will apply in these cases. You're not putting your record as part of a larger system, so other people can't access it. And so the normal types of things, you'll have a chart, you'll do informed consent, you'll talk about the confidentiality that applies, and you'll also talk about the limitations on confidentiality. And one of the things I'll be talking about are 2 of the state laws that may be limitations on confidentiality, and how they interact with your ability to treat physicians. So one of the things that comes up is the exception to confidentiality is if your client tells you that they have a clear and serious intent to commit a subsequent crime involving threat to physical safety, sex abuse, death, or animal torture. And the nice thing about this statute is that it's permissive. You may choose to report, or you may choose not to report. You're protected either way. You can't be sued civilly. And if your client comes in and says, I'm going to go kill my boss tomorrow, you have the ability to go forward and take action to protect that patient or that boss. And this applies to psychotherapists of all kinds, psychologists, LPCs, social workers, anybody that's in the program. You have immunity whether you choose to report or not. And so you can use your best judgment. So if the other thing to remember too is that past crimes, things that they have done unethically or otherwise, are not reportable. Those are protected. Anything in the past is protected. Anything that they might do in the future that involves a future crime would be potentially reportable. You have to use your best judgment to determine whether or not this rises to the level, do I need to go tell somebody? And it doesn't specify who you tell. It says you can tell anybody. And if you do go tell them, then there's no more privilege for those communications. And so you have the option if somebody is doing something and they intended to commit a crime in the future. For example, diverting drugs from a patient. If they choose and they're telling you that, I'm not going to stop doing it, then you have the ability to report that if you need to. The other statute that comes into play is duty to report unprofessional conduct. And I call it the squeal on your colleague rule, but it's basically it's designed that if you see another healthcare practitioner involved in unprofessional conduct, you are required to go report. The big exception though is it does not apply in a treatment situation. And so if your client is telling you, hey, I've committed unethical behavior in the past, you're not required to go forth and tell them. They're your patient. Patient confidentiality still applies. If it rises to the level of a crime, as in the prior slide, then you may go report. But unprofessional conduct basically is defined as contrary to the recognized ethics of that profession. So if it's a physician, it's AMA or Oregon statutes and so on. And so if they have engaged in unprofessional conduct, you're mandated to report unless they're your patient. If you're a patient, you're not required to report. And that applies to any of the healthcare professions in Oregon. There's 23, I think, in the statute. And so for the most part, everything your patient tells you will be protected. Only if it rises to the level of a crime that they're going to commit in the future, or it creates a risk of harm to self or others. That's a common thing that we talk about in the informed consent anyway. If you become a danger to yourself or others, we may take action. If a client becomes suicidal, we may have them hospitalized, we may have them transported, do a variety of things. But otherwise, everything is confidential, and the board is not looking to get into your therapy and unless it arises to the level of impairment. If it rises to the level of impairment, then you as the practitioner will be making referrals either for a fitness for duty evaluation, drug and alcohol treatment, a whole variety of things that might take place. And so your clients can rest assured that what they tell you is not going to go beyond your chart unless it involves a crime of some sort. So one of the things to do is if your client comes in and tells you they may have impairment issues, or there may be other issues, there may be a crime, or there may be things to think about, your job as the clinician is to determine whether or not there is a credible risk. And what's the nature of that risk? Is it a danger of harm to self or others? So if the client is suicidal, you as a clinician know how to deal with that and know how to make the appropriate referrals. So the important part, Beth talked about it a little bit too, is develop a network of referrals in the weekly meetings or in other places where you're consulting with team members, is you can develop a nice referral base and make sure they're talking to the right people. If there are potential board matters coming down the road, they probably want to talk to an attorney who's familiar with dealing with board complaints. Many of the things that the board looks at as a mitigating factor are things that we would want people to be engaged in just for their own good health. Getting treatment for drug and alcohol issues, treating depression, those types of things. And so when a board complaint does come, they have the resources to be more resilient, because one of the things that we see in board complaints is the anxiety and depression and quite a number of emotions all come to the surface at the same time. And so you want to have somebody who has the resources to be able to deal with that. One of the things to consider is, should they self-refer to the HPSP program? That has quite a number of advantages if they self-refer. So one of the things you might be talking about among the referrals is to the HPSP program. And if they refer for drug and alcohol issues, and it's a true self-referral, then they maintain confidentiality. And that, to most practitioners, is very important, is that they be able to maintain, they can continue to work in most circumstances, they do a work plan, they do a whole variety of things. But it's important to explore those options and see what the benefits would be. They should talk to an attorney who is familiar with healthcare issues. As a clinician, that's one of the things that when you come into these situations, is this a situation where the person is at risk of harm to self or others? What do I do in this situation? Talk to an attorney, absolutely. Whether it's me or somebody else, they'll be developing a list of people to talk to, but it's somebody who's familiar with how the licensing board works, how confidentiality works, how HIPAA works, all these types of things play into it. And so talk to colleagues. One of the things you want to consider is, if you're talking to an attorney as a clinician, you don't want to put that in the patient's chart. You want to keep that off to the side as attorney-client privilege. The attorney isn't telling you as the clinician how to behave and how to treat. They're telling you how to go through a decision-making process. And so, at best, you might simply just write down a consult and leave it at that, and have your notes of the consult separate. If you're talking to a colleague who's actually telling you treatment options for this particular physician, then absolutely you can put that in the chart and talk about it. It's important to document, and as a clinician in this program, you'll have a standard file, as if you would a patient chart. Document your thought process. As I suggested, keep consults outside of the chart for the most part, especially if it's to an attorney. And sometimes there is what we call just do the right thing. You might have specific concerns about someone, and talk to an attorney, talk to a colleague. But at the end of the day, you want to err on the side of caution. You want to be helpful. You want to, if somebody is at extreme risk, they might harm somebody, they might harm themselves, you need to take action. And it's appropriate to go ahead and balance the risk of confidentiality versus erring on the side of caution. There's a separate statute for 179505 for public therapists, work through the state and others. They have a clear and immediate danger to others, may be reported to anyone. And you have immunity if you choose not to report it to someone outside your treatment relationship. It's a little bit backwards, but you do have some ability to report. Your ethics, I just chose psychologists. Ethics will come into this as well. You have statutes, you have HIPAA, and you also have ethics. Avoiding harm, take reasonable steps to avoiding harm in patients, That's true for all healthcare professions. And so that's the balancing of, may I disclose without the consent of the individual? And there are some limited reasons for doing that. Certainly for psychologists, the ethics say you can disclose without the consent of the individual to protect the patient from harm. And so it's usually in extreme situations, clear risk of danger to self or others. It's always an exception to confidentiality. And so the fact that they're in treatment with you, hopefully we're going to avoid all that type of thing, but you do have the ability to reach out. The Health Professional Services Program, as I talked about, they contact, if you self-refer, you have confidentiality. The board will not be notified of your identity, and there's just some general reporting. And there is an agreement. There's always a treatment agreement. It can be anywhere from 2 to 4 to 5 years, depending on the license. There will be monitoring during that period of time.
Well, thank you all for attending this conference. I first want to thank our presenters today, who are a group of outstanding physicians and psychologists, and how much we as physicians appreciate what they have done to help not only this program grow and develop, but also to help those people they serve. And I would say the same thing to you all. Thank you for coming into this program to help serve a huge group of healthcare professionals who very much need your help. My name is Don Gerard. I'm an internist and long-term member of the faculty at OHSU. I spent my whole career there as one invested in and involved with young physicians and trying to help them find their course and find their way and find wellness. And Mary Moffat and I worked together for many years on the program that she described today. My role here, other than saying this, is quite short. The wellness program needs to have a barometer about whether or not what it is doing is helpful. And that, of course, runs the risk of asking questions to those individuals who use the program and getting those results back and evaluating them. And that also runs the risk of breaching confidentiality. So colleagues of mine and I, both on our in the Oregon Wellness Program on our executive committee, and consultants that I have recruited outside, have worked for more than a year to put together a survey instrument that we think will be helpful in determining how those individuals who are willing to complete it will be able to determine whether or not it's helped them. And again, we need that information to know whether we're going in the right direction or have to change those directions. So I am asking you, as the health professionals who are providing the services, to personally provide 2 items to clients, and both are voluntary. The first is a survey instrument that we're asking them to put together and complete, put in a self-addressed mail envelope, and send back to the Biostatistics Division of OHSU in the School of Public Health, where we have put all this work together. And the second piece of information that will be included in that handout is a letter written by me, which explains all of the steps and the no risk, if you will, for breaking confidentiality. I won't go through that at this moment, but would ask you to review it as you receive it. But we are asking you to ask each client on each visit to be willing to fill out a questionnaire and return it. If he or she elects not to, that's fine. We are obviously only asking for those who are willing to do it. The risk for confidentiality breakage is virtually none, but of course that's a decision. So that's my the end of my extensive presentation. I do want to thank you again for being willing to invest in our program and those many, many health professionals who need your help. Thank you very much.
Welcome to a demonstration of Doxy.me, the preferred telemedicine platform for the Oregon Wellness Program. My name is Dr. Bradley Bryan, and I'll be walking you through a brief demonstration of the product. For the purposes of orientation, I have two screens set up. The screen on the left is the provider screen. The screen on the right will be the patient screen. Doxy.me can run on most computer platforms as well as tablets. It has been tested on all of our commonly used browsers, including Safari, Google Chrome, Internet Explorer, and Firefox. For use on tablets, including iPads, Google tablets, and Amazon Fire, you will need to download the Doxy.me app from the App Store. We will begin by entering the Doxy.me URL into a web browser. Doxy, doxy.me. The website is easy to use and provides instructional videos as well as additional information to troubleshoot and to assist with accessing the functionality. There is also a chat function to ask questions or receive additional information. The sign up is simple. If you go to the upper right hand corner and sign up as a provider, the sign up is simple, including a first and last name, a room name which should be specific to the provider, and simple since this is what is used by the patient to access telemedicine services. It will ask for an email and password for sign-up purposes. Since I already have an account, we'll back out of the sign-up screen and go to the sign-in screen, which is essentially my email address and password, and I will sign in. Prior to your first visit, you can do a pre-call test, which will test your internet connection along with your audio and video functionality. It's also a good idea to perform a dry run test, if possible, prior to your first telemedicine visit. You'll want to ensure that your webcam is turned on. And you are now available for telemedicine visits. The most important piece is the URL address, which will be provided to patients to access the telemedicine visits. It's essentially doxy.me / and then the name of your room, which I've named Dr. Bradley Bryan. The invite tab is not functional unless you are a paid user. However, you can simply copy the URL address by right-clicking, copy, and this can be pasted into an email, a text message, or can be communicated verbally to the patient. At this point, you are ready for telemedicine visits. We'll next move over to the patient screen to show how they will access the telemedicine visit. On a PC-enabled device, I will open up Google Chrome. And as the patient, I will type in the URL address provided for the visit. Doxy.me doxy.me/Dr. Bradley Bryan. Doxy.me does not require the patient to enter any personal information and can simply type in a name to check in for the visit. This screen shows the video of the patient, and we'll move back over to the provider screen, which shows the video for the provider and the patient queue or your waiting room. Once you see your patient has signed in for the visit, you can click on their name and begin the call. And even though it's the same image, the right screen is the patient screen and the left screen is the provider screen. There is chat function that can be used by both the patient and the provider by simply typing in your message and sending, and the patient can respond on their side. Remember, these visits are not recorded and are transmitted all over an encrypted internet connection. Once your visit is complete, you can simply sign off by hitting the end call function. Next, we'll demonstrate how to access Doxy.me using a tablet app. For the purpose of this demonstration, we're using an iPad and have downloaded the Doxy.me app. If you click on the app, it will ask if you're a patient or healthcare provider. If you're accessing as a healthcare provider, simply hit that button and sign in as you would from a internet browser. Your email address and password, and sign in. And the screens are very similar to those seen on the website. If you're a patient, you'll hit the patient button and type in the URL provided for the visit, and you can enter the room. And it will show if the provider is signed in that that provider is available, and once they click on the visit, then the telemedicine visit can begin. And thank you for reviewing this brief demonstration of Doxy.me, the preferred telemedicine platform for the Oregon Wellness Program. You can contact me, Dr. Bradley Bryan, at bradleybryan@mac.com if you have any questions. Again, the Doxy.me website has a considerable amount of information regarding accessing telemedicine visits and any troubleshooting that might be necessary. Thank you.